So a very good evening to all. Welcome to the session of Journal Club by IAP TVM. And today we are having a very interesting discussion on a very interesting subject, that is regarding post-exposure prophylaxis of after this exposure to varicella in immunocompromised patients, cancer patients. So varicella, as we know, it is a very clinically very significant disease, and in immunocompromised patients, they can develop encephalitis, pneumonia, and such complications and all. And we know that the varicella zoster immunoglobulin is also very difficult to procure, and the cost is also more. And so, I mean, worldwide, the practice has been giving this varicella zoster, but recently, all of us are thinking about changing. I mean, there are papers coming up which thinks about changing this post-exposure prophylaxis to acyclovir and other antiviral drugs and all. So today's Journal Club is headed from Cosmopolitan Hospital, one of a, trademark hospital, a very important hospital in Trivandrum, which has got a rich heritage and all. So we have two mentors from Cosmopolitan Hospital, Dr. Rosemary Lawrence. Madam is a pediatrician. Madam is also a specialist in pediatric intensive care. And Rosemary Madam is also a neurologist also. Also, we have none other than our IAP Trivandrum's treasurer, Dr. Benno. Dr. Benno is working as a neonatologist there. And we have two enthusiastic postgraduates from Cosmo Hospital, Dr.Hiba Abu Thahir and Dr.Cilu Mathew. Both of them are junior residents at the Cosmopolitan Hospital. We have our Journal Club coordinator, Dr. Padmanabhan Sir here. Sir is working as consultant in PRS Hospital and has teaching experience, has many papers published and research. I mean, he is interested in pediatric oncology also. And he has been coordinating this Journal Club for the past few months. And as an expert analyst, we have none other than Dr. Ramankutty Sir. Sir is actually emeritus professor at Achuthamenon Centre, SCTIMST, and Sir is a member of the planning board, and he himself is a research guide for many PhD students and has been awarded many PhDs, and is a multifaceted genius. His painting the exhibition of his paintings is now being going on at a museum near Villambalam also. And I was just mentioning only. So, and we have Dr. Purushothaman Sir, and I hope many more will join. So we will directly go to the presentation. First, we will have the presentation of the article by Dr. Hiba. Over to Dr. Hiba.
Yes, sir. Sir, is the screen visible, sir?
Yeah, the screen is visible. Now we have to make that full screen also. Now it is full screen.
Okay.
Okay, perfect. Thank you.
Thank you, sir. So good evening, respected sirs, madams, and my dear friends. Today, I'll be doing the journal presentation. I am Dr. Hiba Abu Thahir from Cosmopolitan Hospital. So the topic of discussion for today is PEPtalk 3, that is post-exposure prophylaxis talk 3. Oral acyclovir is equivalent to varicella zoster immunoglobulin as post-exposure prophylaxis against chickenpox in children with cancer. Results of a multi-center UK evaluation. The study was done by Cuerden et al. And it was published in the Archives of Disease in Childhood in BMJ Journals 2022. So coming to the introduction, varicella zoster virus is the cause of chickenpox, a highly contagious childhood illness, which in the majority follows a benign clinical course with subsequent immunity. However, for immunocompromised children, primary varicella zoster virus infection can cause severe disseminated disease, requiring hospital admissions and interruption to cancer treatment and rarely death. So in countries which do not routinely vaccinate against varicella zoster virus, it is not feasible to prevent high-risk children from exposure. If exposure to varicella zoster virus occurs, due to its relatively long latency, there is a window to disrupt viral infection and prevent clinical disease with post-exposure prophylaxis. Following significant exposure, 90% of susceptible individuals develop chickenpox without post-exposure prophylaxis. So for post-exposure prophylaxis, we have two measures, that is varicella zoster immunoglobulin and oral acyclovir. Varicella zoster immunoglobulin has been the first-line PEP recommended by the Public Health England guidelines. Its protection is, however, not absolute, and it is a costly and scarce product with the same inherent risk of any blood product. Following a hiatus in varicella zoster immunoglobulin supply and favorable experience from countries such as Japan, where varicella zoster immunoglobulin is not available, oral acyclovir was introduced as an alternative, equivalent choice of PEP by the RCPCH practice statement in 2002. PEPtalk-2 was a study which piloted recruitment to a randomized control trial to directly compare the effectiveness of acyclovir and varicella zoster immunoglobulin as post-exposure prophylaxis in children with cancer across several UK centers. Unfortunately, the results of this pilot indicated that it was not feasible to recruit sufficient eligible participants to power a full-scale randomized controlled trial. In view of this, an alternative approach was proposed. So our PEPtalk-3 aimed to add to the evidence base for choice of post-exposure prophylaxis following exposure to chickenpox in children with cancer. So the objective of our study, the primary objective was to compare the occurrence of chickenpox in children with cancer who received varicella immunoglobulin or acyclovir as post-exposure prophylaxis. And the secondary objective of the study was to compare the disease severity in children that developed chickenpox despite immunoglobulin or acyclovir. The methods. This was a UK multicentre service evaluation of children with cancer who received either varicella zoster immunoglobulin or acyclovir as post-exposure prophylaxis following significant exposure to varicella zoster virus disease over a 24-month period from 1st May 2018. The eligibility, the inclusion criteria were children under 16 years of age with a diagnosis of cancer and or having received a stem cell transplant, varicella zoster virus seronegative at the point of exposure, or if not known, seronegative at cancer diagnosis, and having received post-exposure prophylaxis following significant exposure to varicella zoster virus. In line with the Public Health England guidelines, significant exposure was defined as contact with a case of chickenpox between 48 hours before onset of rash and crusting of lesion of a household exposure or non-household exposure if in the same room for longer than 15 minutes face-to-face. The sample size, the study was powered to detect large differences of about 20% between groups, that is a power of 80% and 5% significance, and was designed when it was assumed number in each group would be similar to about 50 per group. Statistical analysis, the number of cases of breakthrough varicella disease as well as severe disease in each group, that is varicella zoster immunoglobulin versus acyclovir, was summarized as percentages with 95% confidence interval and compared using a two-sided Fisher's exact test with 5% significance level. The difference between the percentages was also calculated with 95% confidence interval. The outcome measures. The primary outcome was the evidence of breakthrough varicella within 6 weeks of varicella zoster virus exposure and treatment with post-exposure prophylaxis. In cases where breakthrough varicella zoster virus infection occurred, secondary outcome included clinical severity of chickenpox, assessed on day 3 to 5 of illness using a standardized score, level of hospital care and duration of admission, delay in cancer treatment, and other morbidity or mortality resulting from varicella zoster virus infection. So this is a scale used to assess the severity of illness, where the variables used are rash, fever, systemic signs, and subjective assessment done by the research assistant. And a score was given, and the severity, based on the total score, we can classify as mild, moderate, or severe disease. Coming to the ethical consideration, PEPtalk-3 was a non-funded clinician-led service evaluation supported by the Public Health England guidelines. This study did not involve any allocation or randomization of cases to either type of post-exposure prophylaxis and did not in any way influence choice of PEP administered or subsequent management of the child. St. George's University Research Governance Team and the Public Health England Research Support and Governance Office reviewed the protocol and confirmed that this study was a service evaluation and therefore did not require formal ethical approval. So coming to the results, a total of 105 eligible patients were registered during the study period from 9 primary centres in the UK. Median age at the time of exposure was 4.9 years, ranging between 1.1 to 10.5 years. The most frequent diagnosis category was acute leukemia, 61%. There were 2 patients, that is 1.9%, who had received hematopoietic stem cell transplant and 2 patients taking prophylactic acyclovir prior to exposure. Coming to the serostatus and exposure, most patients were VZV seronegative at diagnosis. And the serostatus was unknown for 7 patients, 6 were equivocal and 3 were positive. At the time of exposure, 53 patients were varicella zoster virus seronegative, 51 were unknown or not retested, and 1 was equivocal. The 3 patients who were seropositive at diagnosis were all seronegative at exposure. The majority of the varicella zoster virus exposure were reported to have occurred at school, 60%, followed by household, 14.3%, and then the hospital or clinic, 14.3%. Coming to the post-exposure prophylaxis treatment analysis, of the total eligible patients requiring PEP, 86 were prescribed acyclovir, 18 were given immunoglobulin, and 1 was given valacyclovir. All patients receiving varicella zoster immunoglobulin were registered within the first 4 months of the study prior to the national restrictions on varicella zoster immunoglobulin use. Acyclovir was most frequently prescribed 7 days after exposure. The most common dosing regimen used was 10 mg per kg 4 times a day. Coming to the post-exposure breakthrough infection, there were a total of 7 breakthrough infections reported in the 103 patients who were followed up after receiving post-exposure prophylaxis. The median age was 3.8 years, range between 2.3 to 8 years. In the patients who had received acyclovir, 5 out of the 84 developed clinical varicella infection, compared with the 2 out of 18 group in the varicella zoster immunoglobulin group. So the difference in proportion for acyclovir versus PEP is minus 5.2%, 95% confidence interval minus 20.5 to 10.2, and the exact P is 0.6. Coming to the discussion, the results from the PEPtalk 3 are comparable with the existing international research supporting acyclovir as an effective alternative to varicella zoster immunoglobulin for post-exposure prophylaxis. In this study, 5 out of the 84 patients who received acyclovir developed a breakthrough infection compared with 2 out of 18 of those who received immunoglobulin. The literature suggests varicella zoster virus breakthrough in 3.1 to 13% of patients receiving acyclovir as post-exposure prophylaxis and 5 to 22% of patients receiving varicella zoster immunoglobulin as post-exposure prophylaxis. The study has also demonstrated inconsistency in the varicella zoster virus post-exposure prophylaxis prescribing practice. This study supports updated guidance from the Public Health England to standardize acyclovir dosing at 10 mg per kg 4 times a day from days 7 to 14 post-exposure in susceptible immunocompromised children aged 4 weeks to 17 years. The maximum dose 800 mg 4 times a day. Individuals with the IgG titer of varicella zoster virus less than 150 milli international units per ml in a quantitative assay or negative or equivocal in a qualitative assay should be offered post-exposure prophylaxis. The primary source of varicella zoster virus exposure in our patient cohort was school or nursery. Vaccination of household contacts of immunocompromised children is recommended. Acyclovir is approximately 50 times less expensive than the equivalent dose of varicella zoster immunoglobulin, which is a blood product with its complication like transfusion reactions. The administration of varicella zoster immunoglobulin via intramuscular injection can be unpleasant for the children and could pose a risk if the patient is thrombocytopenic as a result of chemotherapy. In the context of the growing evidence base, acyclovir has the potential to be a safe and cost-effective alternative. This study was limited by the imbalance between the number of patients receiving acyclovir and immunoglobulin. Of the 105 eligible patients registered, 86 were prescribed Acyclovir. This is actually secondary to the UK severe national shortage of immunoglobulin in June 2018. All patients who received immunoglobulin was registered within the first 4 months of the study, which would support this further. It was therefore not possible to sufficiently power the study to reach statistical significance or identify specific risk factors for breakthrough infection. A potential source of bias in this evaluation is that 17 centers initially agreed to provide data for the study, but only 9 centers did so. However, the 9 centers that did provide data had a wide geographical spread across Scotland and England, and 4 were previously using varicella zoster immunoglobulin, and 5 were Acyclovir centers. So coming to the conclusion, this study supports the growing international body of evidence that Acyclovir is a safe and effective alternative to varicella zoster immunoglobulin for post-exposure prophylaxis. While the study was unable to provide a statistically significant comparison, it provides reassurance that Acyclovir is not inferior to varicella zoster immunoglobulin as post-exposure prophylaxis treatment for children with cancer. Thanks.
Thank you, Hiba, for that crystal clear and crisp presentation. Now, the analysis part can start. That will be presented by Dr.Cilu Mathew, Junior Resident, Cosmopolitan Hospital. Over to Cilu Mathew.
Good evening, all. I am Dr.Cilu Mathew. I will be doing the journal analysis. Since this is an observational study, I have analyzed it using the STROBE checklist, that is, strengthening the reporting of observational studies in epidemiology. It consists of 22 items under the heading of title and abstract, introduction, methods, results, discussion, and other information, which are used to ensure adequate reporting as well as assessment of the strength and weakness of the study. Coming to the title is Post-Exposure Prophylaxis Talk 3. Oral Acyclovir is equivalent to varicella zoster immunoglobulin as post-exposure prophylaxis against chickenpox in children with cancer. Results of a multi-center UK evaluation. This study title is a reflective of the study question as well as study outcome. The study population, that is children with cancer is also mentioned in the title. However, the study design is not given. Abstract. Here background is not included. As said earlier, they did the study in UK during a period when there was shortage of varicella zoster immunoglobulin. So there was a need to find out an effective alternative. It was not given in the abstract, while the methods, results, and conclusions are well given. Objectives. Specific objectives mentioned. The primary objective is to compare the occurrence of chickenpox in children with cancer who received varicella immunoglobulin or acyclovir as post-exposure prophylaxis. Secondary objective is to compare disease severity in children that developed chickenpox despite post-exposure prophylaxis. The question is, did the study address a focused and clinically relevant issue? Yes, because the acyclovir is approximately 50 times less expensive than varicella zoster immunoglobulin. It does not have any supply constraints that come from using blood products. Also, the varicella zoster immunoglobulin has complications related to transfusion, as well as IM injections could pose a risk if the patient is thrombocytopenic as a result of chemotherapy. Hence, if the efficacy of acyclovir as post-exposure prophylaxis is proved, it can be used as a safe and cost-effective alternative. Methodology. The study design is prospective cohort study. We know that incubation period of chickenpox is 10 to 21 days. Therefore, a follow-up study can be easily done. Setting, multicentric. Initially, 17 centers agreed to provide data for the study, but only 9 did so. However, these 9 centers include a wide geographical area and it provided strength to the study. Study period is over a 24-month period from 1 May 2018. Significant exposure is defined. The follow-up is about 6 to 8 weeks following exposure. Data collection is through data provided by healthcare professionals at the participating oncology centers and through the receipt of varicella zoster immunoglobulin supply request. They also made a study pro forma to collect data on demographics, cancer diagnosis, current and recent oncology treatment, varicella zoster virus error status if known, and type of post-exposure prophylaxis received. Participants, the eligibility criteria, source and method of selection of participants, and methods of follow-up are described. Variables, outcomes, and exposure clearly defined. The effect modifier is not addressed. That is, the timing of initiation, dose, and duration of post-exposure prophylaxis can alter the outcome. The incubation period of chickenpox is 10 to 21 days. It is known that acyclovir, when given when initiated at day 7, has a better outcome than that given before 7 days. In this study, there was a difference in the timing of initiation. While 2 were already on long-term acyclovir prophylaxis, 39 received the drug before 7 days, 40 patients on day 7, and 6 patients after 7 days. This can alter the outcome. However, it was not. How it altered the outcome was not mentioned. The potential source of bias described. There is only small sample size in varicella zoster immunoglobulin group. While 87 patients received acyclovir, only 18 patients received varicella zoster immunoglobulin. It could be a bias. Next potential source of bias is that 8 centers withdrew from the study. The reason for that was not known. The sample size, calculated sample size of 50 in each group to attain sufficient power was not achieved. Statistical methods, the number of cases of breakthrough varicella disease as well as severe disease in each group was summarized as percentages with 95% confidence interval and compared using a two-sided Fisher's exact test with 5% significance level. The difference between the percentages was also calculated with 95% confidence interval. Results, participants, the number of participants at each stage of study was not described. 105 patients met eligibility criteria, but finally the results were calculated among 103 patients. That is, 2 patients lost follow-up, the reason for which was not mentioned. It would be better if they use a flow diagram. Descriptive data like patient characteristics, the source of infection, and follow-up time was given. Other analysis, the study also noted a difference in time at which post-exposure prophylaxis was initiated among patients, and they described primary source of varicella zoster virus exposure. In their study, the main primary source was school or nursery. Discussion. Clinical varicella zoster virus developed in 5 out of 84 of the acyclovir group, that is 6%, 95% confidence interval 2 to 13.3, and 2 out of 18 of the varicella zoster immunoglobulin group, that is 11.1%, and 95% confidence interval 1.4 to 34.7. The difference in proportion for acyclovir versus varicella zoster immunoglobulin is minus 5.2%. 95% confidence interval minus 20.5 to 10.2, and exact p-value is 0.6. Here there is an overlap of confidence interval, and the difference in proportion include a 0 as a value, and exact p is more than 0.05. Hence, we could not reject the null hypothesis, and acyclovir is a safe and effective alternative to varicella zoster immunoglobulin as post-exposure prophylaxis. Breakthrough infections were scored as moderately severe in 2 of 7 cases, and 5 were of mild severity. Limitation. There was an imbalance between number of patients received acyclovir and varicella zoster immunoglobulin, and the timing, duration, and dosage of post-exposure prophylaxis varied. The strength of the study, as I said earlier, is multicentric, covering a wide geographical area. Interpretation. Various studies suggest varicella zoster virus breakthrough in 3.1 to 13% of patients receiving acyclovir as post-exposure prophylaxis, and 5 to 22% of patients receiving varicella zoster immunoglobulin as PEP. However, there are no similar studies comparing the 2 cohorts. All breakthrough infections were either mild or moderate in severity. This shows the effectiveness of both the drugs as PEP. There was a notable variation in timing, duration, and dosage prescribed of acyclovir among the centers. The primary source of exposure in this study was school or nursery, that is 60%. Costa et al. Reported that 38% of 52 reported varicella zoster virus exposure episodes in the French cohort of children with cancer occurred at nursery or school. This might be due to the fact that in these countries, varicella vaccination is not included in the routine childhood immunization schedule. Impression. It is a multicentric study which provided strength to the study. And also there is an overlap in confidence interval among two groups. And the difference in proportion for acyclovir versus varicella zoster immunoglobulin includes 0 and p-value is more than 0.05. Hence, acyclovir can be considered as a safe and effective alternative to varicella zoster immunoglobulin as PEP. However, further studies with a good sample size are required for confirming the superiority of one over the other. Thank you.
Thank you for that excellent presentation. Now, we would like to know the expert opinion. So I request Dr. Ramankutty sir to offer his thoughts on the presentations and article. Thank you, sir. Over to Ramankutty sir.
Am I audible?
Yes, sir.
Okay.
You're audible,
Good evening. Sir. Good evening. Actually, this is a very straightforward paper, not much of complication, so there's nothing much to say, but except I'll point out a few things. But before I come to that, I think the presentations were excellent and they did a good job. And I'm very happy to see that people are following the guidelines like a strobe and all those things, so according to the design of the study. And it was correctly identified as a cohort. Usually people say prospective study, longitudinal study, and all sorts of nonsense. It is a cohort. Anything which is followed up is a cohort. So I think you have to firmly say that it is a cohort. So that in that I am very happy. Now coming to the study itself, they had a lot of limitations. They themselves have said that to answer this question of whether one drug is superior to the other, ideally they should have done a clinical trial, but because of various reasons they were not allowed to, or they could not do that. So they did the next best thing, which is to look at the thing happening as it on the ground. And they have called it a service evaluation, which is that they did not interfere. They probably did not even interview the patients, because if they wanted to interview the patients, they should have had a ethics committee clearance. They have clearly stated they did not have that, which means that they just collected the information from the hospitals, which is fine. I mean, so actually a lot of things can be done that way also. So they have looked at this thing from several hospitals, but they failed to achieve the sample size. And even though they have found a big difference in the complication rate between the two groups, actually it was not statistically significant. So that is the catch in the study, in the sense they go on saying that the acyclovir is safe, but there is no statistical evidence for that. Actually, and they themselves say you need further studies. So at this point, my question is, why did they rush to publication at this stage? They should have waited, or maybe recruited more centers, or I don't know what they could have done. Or they might have had their own constraints because of logistic reasons, whatever. But so that remains still question. So the question is still not resolved. To me, the evidence is not there to say that it is safe. Of course, it's very less expensive and all that, and probably that is what is being followed in most cases. But if you want to prove one thing, you have done it. You have to do it properly. So that is my opinion. Otherwise, it's a nice paper. It gives you a lot of information, etc. Thank you.
Sir, if you don't mind, there are 2 questions in the chat box. I think we can attempt that right now itself. That is, one is, sir, the p-value more than 0.05. So how does it make it significant? One, Dr. Deepa Binod has asked, sir.
It is not significant. That is what the presenters also said. It is not significant.
Yes, sir. And the severity of the exposure was not considered in the outcome analysis.
Yeah, that also was pointed out that they did not look at the effect modification by other factors like timing of the exposure, severity of the exposure, etc. So that is a limitation. They themselves have agreed that it's a limitation. So so that's why I'm saying, these conclusions are not very strong. They're not based on very good evidence. So it is still shaky.
I think the last slide, sir, she mentioned p-value was more than 0.05. I think I must have read it wrong, sir. I'm sorry, but I think she
0.6 or something, isn't it? It is 0.6.
She said as p-value is more than 0.05, the study was taken as significant, sir. That's why the query I had put, sir.
I think
Cilu can you bring back that slide?
Ma'am, it's not like that. I said p-value is more than 0.05. So the study is not significant.
Can you just put up that slide once again, Cilu?
One minute.
Yeah, no problem. It must be a mistake. I'm sorry.
Sorry.
You can take your time. No issues. You can share it once more. Try screen sharing once more.
Screen sharing.
Can
we go back on the slides?
It's okay, sir. Corpilla. I think I joined a little late. That's fine. No worries, Cilu. Don't worry.
I think she is very clear that it is not significant. So,
yes, sir.
So that way there's no confusion.
Sir, if we are repeatedly telling that it is not significant, then why is the conclusion like Acyclovir can be used as post-exposure prophylaxis?
Yeah, exactly. That is my question. I don't agree with that statement. Based on this evidence.
Yeah, it is not significant. Therefore, there's no difference in the effect between the Acyclovir, and that's what I understand.
Null hypothesis is proved that.
And even the confidence interval, sir, it's actually quite wide interval, sir. So does that affect the quality of?
Yeah, that's true.
It's between 1 to, I think some of the studies that she has mentioned, the confidence interval is between 1 to 34 and 54, sir.
Correct.
It's a whole lot of
also it can affect the confidence interval.
Yeah. So how significant is
this study is not significant, ma'am.
Yeah.
Okay.
Okay. Ramankutty sir, can we go on?
Yeah. I mean, any other question?
Yeah. We are. Covering each milestones in this journey till we reach the end. I would like to request Dr. Padmanabhan sir to share his thoughts on this study.
See, actually, I was a person who normally I never suggest a journal, but in this case, because there was some problem in picking up a journal, I suggested this journal because from a practical point of view, it's very significant. I had asked a question in the previously. Is the varicella zoster immunoglobulin available in India? Have we come to, do we have a choice or don't we have a choice?
I think we have the neonatologist from Cosmo joined with us, Dr. Benno sir, and we have been discussing this point over phone. Is Benno sir available?
Yes, sir.
Can you, sir, please help us here?
Sir, can you just repeat the question, sir?
The question is varicella zoster immunoglobulin available in India? Because you might be giving it to newborns whose mothers have chickenpox. Is it available?
Sir, to start with, actually we get this normal immunoglobulin, just the normal IVIG, from a company which is actually Reliance. So actually I inquired with them. What they were saying is they used to get this varicella zoster immunoglobulin maybe like 5-6 years back as imported product, which used to be very expensive. And right now it is not available anywhere in India. And the reason what they're saying is probably the donor of availability of the donor is actually very less, since it's a blood product. So as of now, this varicella zoster immunoglobulin is not present. It's not available. What we give is a normal immunoglobulin, sir, as per 1 gram per kg.
But it may not, it is not given in any guidelines. It may not be effective also, isn't it?
Yes, sir. Yes, sir.
Okay.
So
now, my thing is, because my opinion was asked, why did I pick up the article, is that this is a very important point, because if acyclovir can be given to newborn babies to prevent the, we are more interested in the perinatal transmission. That's where we get more involved in this. When the mother has chickenpox and she delivers a child. And therefore, I was just thinking whether we can extrapolate it into newborn practice also. Varicella immunoglobulin is not available. Wouldn't it be better than the other immunoglobulin, the normal immunoglobulin? Number one. Number two is, I also felt in the initial study, this was not a very randomized controlled trial, or it was not very well done, but still it got it published in the Archives of Pediatrics. It's a very well-known international British journal. And this sort of, practice, does it affect, this sort of publication, does it affect a practice? That's what I want to ask Ramankutty, because we can't do a better study than this. Yes. And we have only oral Acyclovir. But tomorrow, if there is a leukemia patient who gets exposure, will this study be enough for us to change a practice and give acyclovir and not immunoglobulin? If zoster immunoglobulin is not available, is it the strength of the study enough for that? There's $1 million question we have in front of us. And yeah.
I would, yeah, if you put it that way, I would say no. This, based on this evidence, I wouldn't advise that. But then practical considerations like non-availability of immunoglobulin might force you to give cyclovir. That's a different issue. But you can't justify that quoting this study, because this study doesn't prove anything. It doesn't really prove that acyclovir is as good as the other thing.
But sir, in the presentation itself, there was one slide which showed that comparing the post-exposure prophylaxis, the breakthrough varicella was actually lesser with the oral acyclovir. There was one slide like that. I think Dr. Mary Madam, can you contribute regarding that point actually?
So they're all not well-powered studies. So they're not strong enough to give a recommendation, actually speaking. We would need a bigger sample size, definitely, probably randomized controlled trials to get a definite answer. But like Sir Padmanabhan Sir said, it's practically difficult to conduct such trials. So that is why we are not able to come with a definite answer. So currently we have to just...
worldwide, what is, while searching literature, is there anywhere there is a change in practice regarding this post-exposure prophylaxis like that? No, or probably we'll be, because there are when we go through literature, both are being given actually. Acyclovir is also given, as well as this for certain patients, varicella zoster immunoglobulin is also given. What is the comment on that actually? Did you come across?
Inconclusive, sir.
Yeah. I would say, this is not a very minor decision in clinical practice, a major decision. If you have a leukemic patient who's you have treated and they've gone through all the hassle, and he gets exposed to chickenpox, which can happen very well. Yeah. If you don't act on it, definitely, if he develops severe chickenpox, he can die. I've seen at least one child developing very serious problems. Similarly, when the mother has a chickenpox and I have a newborn baby, in our days, SAT hospital days, I remember it was almost a death certificate for the newborn baby. Now, when you don't have I think varicella zoster immunoglobulin, you may have to give it the acyclovir a try, because you don't have anything fair, and it might be at least some justification is given by this study. Now, after exposure, you give it after 7 days. That's what it is written here. What about a newborn? I think you had to give it at birth because the exposure is fetal, is it not? Transplacental.
Yeah.
When a newborn, that's where we pediatricians get more involved. When we are asked opinion what to do to maybe once in a while, but I have been asked at least 4 or 5 times. And those days, I don't remember what we gave, but I don't find any point in giving serum immunoglobulin. I don't know how much antibody it will have against this one. But definitely, if varicella zoster immunoglobulin is available, that will be the choice because that is what is internationally accepted. All guidelines give that.
Sir, sir, I would like to request Dr. Purushottam sir to share his thoughts on the article and the subject here, sir. Please, sir.
First of all, I congratulate Dr. Hiba and Cilu and the Cosmo team. This is an excellent presentation. I have 3 points. The first one, of course, the concern by Padmanabhan sir, whether it should be recommended as a practice. When we consider these sort of things, first question, the probability need to be considered. Based on pharmacological basis. Acyclovir, all of us know, it is useful after the symptoms started and that is recommended. But how much it will work as a prophylactic pre-EP, because the work of this pharmacokinetic work is in multiplying virus, the phosphorylation. That is the mechanism. The 2 drugs work in a different manner. The immunoglobulin works at the day 1 itself because the attachment is even the earliest number of this virus will be attacked by the immunoglobulin. But the pharmacokinetics is 20% only absorbed, and that will work only with the viremic phase, which you are not sure. It is 7 to 9 or 10 days, and that is varying. You can't be sure about that. So the possibility of this thing working itself is very unlikely. In that situation, even if a study comes as positive, we should think twice before it is being put into practice. So the power of the study should be that much to come to a conclusion. So that is the first thing that we need to consider. I don't know, Ramankutty sir, at a statistical level, this question is to be considered. That also is to be considered. What is the probability of this thing to be put into practice, considering the pharmacokinetics and that part? That is one question to sir opinion about it. So, Randamatte chodyam is the immunological status they considered. All the kids at the time of starting were negative immunologically. Why they didn't consider? There is totally important immunological aspect also. It is cell-mediated immunity. So a person can be immune by 2 mechanisms. Just one only is given consideration. Why not the cell-mediated immunity? So it may not be possible to measure it, but that must have worked here, protecting. So it's not 100% rule that negativity by immunoglobulin, they're all susceptible. No. There is a chance that the varicella or the vaccination or whatever thing, there is a cell-mediated immunity component. It is just like the COVID status also. We are going behind the immunoglobulins and ignoring the cell-mediated part. So that is one of the major points. The second point, the 103 kids belong to different immunological strata, because considering the 2 things, they are of different malignancies, they are on different chemotherapeutics. So just the total number cannot be taken as a uniformity. So there can be CNS malignancy without much of a hematological problem contributing as such. And the drugs used, few of these may be not that much of suppressing. So that's a varied group of population with the immunological interference totally different. And out of this thing, maybe this is 64%, 61% were acute leukemias, and the other numbers less like that. So that is one major point to be considered. So I think based on this, the conclusion cannot be justified. Ramankutty sir, your opinion, sir.
No, my opinion about I don't know whether I get you correctly. What you're saying is that this is not a homogeneous group, right?
Yeah, right, sir.
Which I totally agree. But the problem is that even for this group, this is not a good sample size. So if you further stratify, then it will be, we will not be able to answer any question because there will be so few in each stratum. So that is the problem here. So that's a major constraint. So there are things where you cannot have any answer, and this is a situation like that where you really don't have the numbers to conclude either way definitively. So that is we are in a helpless situation.
So for the message I want to give to everybody is, just because something is published in the international journal, don't jump into conclusions. That's what I wanted thing to be thing, because normally
quite true.
Published in an archives, I would have changed the practice straight away. Why not? But that is something that unless somebody is able to think around and think about the statistical analysis, the way the design of the study, everything. Therefore, this has now what Dr. Purushothaman has said and what you have said, I have changed my opinion, because I thought now I will give a cycle, because you are in a position in which you have not much choice. In a newborn, as you say, you may give immunoglobulin, or immunoglobulin is not that effective. Nowhere they have written the pooled hemoglobin is effective. Therefore, you might give something which is worth, and therefore I would have given acyclovir from birth. And well, the other one, I would now think about whether to give or not when there's an exposure. Okay. Therefore, I think this journal club was very useful, because what we discussed, we come to understand how to evaluate we clinicians, we are interested whether we should change our practice or not. Now, to the students, I would say this is a common question asked: when do you change your practice when you find an article? The answer to it is like that. First, you read it, then you discuss it with your friends and colleagues. That's what number 2. We have done it today very well. Then you have to see whether the same results are obtained in multiple studies across continents. This is very important in asthma and all that. Therefore, this is just a beginning. We have no other study. We are pushed to a corner. We might give some importance. Otherwise, now it is published in a very important journal. I don't think it should change our practice. Thank you.
Thank you, sir. Ramankutty sir, can I ask a question, sir? Doubt, sir?
Yeah, sure. Yes, you can ask anything.
Sir, I'm showing a slide from the presentation, sir. So for the, the lesser informed and all, the key results is shown here, right? Clinical varicella zoster. So, sir, the sentence, the difference in proportions for acyclovir is versus VZ-IG is minus 5.2%, 95% confidence interval, minus 20.5 to 10.2. Exact P is equal to 0.60. So hence acyclovir is safe and effective alternative to VZ-IG or VS. Sir, can you, sir, I'm sorry to ask you, sir, I should have prepared more, but can you just...
It's not minus.
Pardon?
It's just, that's a hyphen, actually. So.
No, ma'am, it's
okay,
minus.
okay, fine.
It is minus. It is minus.
It is minus.
Okay, minus 5. That one. Okay, correct.
Sir, can you please, we know that the time is not limited. So
I don't agree with the last sentence. You can't conclude like that.
Yeah.
That's what we have been talking all along. Yeah.
Sir, the difference of proportions for acyclovir എന്ന് പറയുമ്പോഴത്തേക്ക് നമ്മൾ ഉദ്ദേശിക്കുന്നത് എങ്ങനെയാണ്, sir? Like, ഇപ്പം 84 പേരിൽ 5 പേർക്ക് ഉണ്ടായി, 18 പേരിൽ 2 പേർക്ക് ഉണ്ടായിട്ടില്ല. അപ്പൊ തന്നെ നമുക്ക് അവിടെ തന്നെ ഒരു ഇഷ്യൂ ഉണ്ട്. കാരണം അവിടെ 84 പേരും ഉണ്ട്, ഇവിടെ 18 പേരും ഉണ്ട്. അപ്പൊ ഇവിടെ പെർസെൻറ്റേജ് തന്നിട്ട് കോൺഫിഡൻസ് ഇന്റർവെൽ തന്നിട്ടുണ്ട് 95% കോൺഫിഡൻസ് ഇന്റർവെൽ. പക്ഷെ അത് വെച്ചിട്ട് നമുക്ക് ഇത് എങ്ങനെയാണ് സാർ ഇത് നമ്മളൊരു കൺക്ലൂഷനിലേക്ക് ഇവിടെ എത്തുന്നത് സാർ? ഇത് എങ്ങനെയാണ് നമുക്കത് പ്രോസസ് ചെയ്തെടുക്കാൻ പറ്റുന്നത് ഞാൻ ചോദിക്കുകയാണ് സാർ. കുറച്ച് സിമ്പിൾ ആയിട്ടൊന്ന് പറഞ്ഞു.
പെർസെൻറ്റേജ് എന്ന് പറയുമ്പോൾ ഒരു 1% 6 and other percentage is 11 അല്ലേ?
11, അതെ സാർ.
അപ്പൊ അതിന്ന് 11 6 കുറയ്ക്കുമ്പോഴാണ് 5 കിട്ടുന്നത്. So that is the difference in percentage.
Okay.
That's all. But then the 95% CI is from minus to plus, which means you cannot exclude 0. It could be 0 also.
Okay.
അതുകൊണ്ടാണ് അത് കൺക്ലൂസീവ് അല്ല എന്ന് പറയുന്നത്.
ഓക്കെ. അപ്പൊ ആ ലാസ്റ്റ് സെന്റൻസ് അപ്പൊ അവിടെ നമുക്ക് ആവശ്യമില്ല അല്ലേ?
എനിക്കറിയില്ല. How did creep there? I don't know.
ഓക്കെ. അപ്പൊ ഈ ഡിഫറൻസ് ഇൻ പ്രൊപ്പോർഷൻസ് നമ്മളിപ്പം ഈ രണ്ടിന്റെയും ഡിഫറൻസ് ഈ കണ്ടുപിടിച്ചാൽ നമുക്ക് ഒരു കൺക്ലൂഷനിൽ എത്തുമോ സാർ? അതായിരുന്നു എന്റെ ഡൗട്ട് ആക്ച്വലി. ഇപ്പം 84
difference in proportions is a legitimate test, statistical test, because you have 2 groups and you have 2 proportions to compare. Then you look at the difference in proportions and look at the 95% CI. So if that is significant, then you can conclude that there is a significant difference in proportion. I square ഒക്കെ ചെയ്യുന്നതിന്റെ കുറച്ചുകൂടെ അടുത്ത ലെവലിലുള്ള ഒരു ടെസ്റ്റ് ആണ്.
I just want to ask Ramankutty one final question. If I had sent this article to you and you were the evaluator for a journal, would you have approved it or not for publication?
I probably would have approved publication because I mean, this is very personal. I'm a very kind-hearted reviewer. I try to publish as many articles as possible because people go to a lot of trouble to write up the results, which itself is commendable. But then I wouldn't let them to claim so much or anything. I would
some of the conclusions you cannot claim.
Yeah. I would definitely say that it has to be toned down and say that, and then if the editor can decide. I would say if you say you don't use such strong language, but if you think it's worth publishing, I have no objection like that. That would be my reviewer's comment.
Thank you, sir. Dr. Krishnamoorthi, sir, you can unmute and speak, sir.
Hello.
Yes, sir.
Hello.
Yes, sir, you're audible, sir.
ഇപ്പോഴത്തെ ഈ കേൾക്കാമോ?
കേൾക്കാം സർ.
നമ്മളുടെ ഇപ്പോഴത്തെ ഈ സ്റ്റാറ്റിസ്റ്റിക്സ് വെച്ചിട്ട്, അതായത് 84-ല് 85-ൽ 5 and 2 out of 18 എന്നുള്ള ഇത് വെച്ചിട്ട് how do we conclude that Acyclovir is equal or better than varicella zoster? അതായിരുന്നു എനിക്ക് താങ്കളുടെ ചോദ്യം അതായിരുന്നു തോന്നുന്നു. I think in my reading we cannot come to that conclusion എന്നുള്ളതാണ് എനിക്ക് മനസ്സിലാകുന്നത്. Because ഇത് രണ്ടും more or less same numbers ആണ് വരുന്നത്. And അത് കാരണം you may need a more detailed study or higher numbers വേണം to arrive at a conclusion. This is inconclusive എന്ന് മാത്രമേ നമുക്ക് പറയാൻ പറ്റുള്ളൂ. That is my reading. Please correct me if I am wrong.
We are all agreed on that.
Yes. We are on the same page.
Thank you, sir. Sir, one more question is in the chat box actually. The question is, varicella zoster immunoglobulin is not available, making Acyclovir the only available prophylaxis. So is there any need for this comparative study? So again, the practical aspect. The practical aspect they're asking, sir, actually.
Yeah, it's I don't know, in the situation may be different in England and India and all that, right?
Sir, actually in everywhere, the point is, sir, this after this vaccination has come out, the incidence of varicella is itself very low. So that is one of the reasons why they have stopped, decreased the manufacture of BCG. That is another thing actually. So Rosemary madam, outside India and all, what is the status like? Varicella zoster immunoglobulin is still.
I have no idea, sir. I wouldn't
scarcity of access and means, right? The availability of access and means. അങ്ങനെയല്ലേ? So നമ്മൾ ഈ സ്റ്റഡി നടത്തുമ്പോൾ തന്നെ varicella zoster immunoglobulin കുറച്ച് റേഷനിങ് ഉണ്ടായിരുന്നെന്നാണ് ഞാൻ മനസ്സിലാക്കുന്നത്. അങ്ങനെയല്ലേ ഹിബ? അല്ലേ ഹിബ അങ്ങനെയല്ലേ പറഞ്ഞത്?
Yes.
ആദ്യം മാത്രമേ അവൈലബിൾ ആയിരുന്നുള്ളൂ, പിന്നെ അവൈലബിൾ ആയി. They had no choice.
Sir, the next question is the same question asked by Padmanabhan sir actually, asked by Dr. Deepa Binod. Will IVIG help instead of varicella zoster immunoglobulin? I think Benno, if he's there, he can also contribute actually. Benno, undo. Hello. So one question has come. Will IVIG really help instead of varicella zoster immunoglobulin? One question has come, sir. So.
Sir, if actually at present, varicella zoster immunoglobulin is available. That is what I said previously. And instead of that, we are giving only IVIG. The reason being, our sufficient donors.
Yeah.
And this used to be imported like 5-6 years back. This varicella zoster immunoglobulin used to be imported with double the price. So, cost effective. So, hence.
So I mean, this immunoglobulin will also contain this antibodies. Concept.
So the level of the antibodies will be very low, sir.
Very low. Yeah, that's right.
Yeah.
So is there any other mechanism? I mean,
the pooled serum. You must be lucky to have a.
And one more
Acyclovir.
Yes, sir. Okay. One more, comment has come from Krishnamoorthi, sir. Do you want to vote that varicella vaccination should be universal? I think definitely the answer should be yes, sir. Do you want to vote that varicella vaccination should be universal? Even though it is not now in the... Yes, sir. I mean, the universal vaccination has brought down the varicella percentages in many countries around the world, actually. So even though now it is not included in the national immunization schedule, as a part of, the policy making and all, probably sooner or later we will also have that given free to all. Actually. That's what I feel. Sir?
Yeah, I think previously there was a worry that, if you give varicella vaccine, it will be shifted from pediatric age group to adult age group, and we will have more varicella zoster and all that. If WHO is definitely advising, if you can afford, you should definitely take it. That is the
okay.
Krishnamoorthi sir on the mute. Krishnamoorthi sir on the mute.
Hello. Can I just add something here? The UK varicella vaccination is not compulsory. It is not being given. Basically, when varicella vaccination was introduced, the thought behind that was that when a child gets varicella, the parents have to take time off from work and all that, and it leads to loss of productive man hours or loss of productive woman hours and all that. Our fact still holds. That's ഈ പറഞ്ഞ varicella വരുന്ന കുട്ടികളെ completely ഡേ കെയറിലും കാര്യങ്ങളിലും പോകാതെ
Krishnamoorthi sir muted ആയി പോയായിരുന്നേ.
പേരൻസ് varicella ഉള്ള കുട്ടികളെ ഡേ കെയറിലും ഒക്കെ രണ്ട് കേസിൽ കൂടുതൽ ഡേ കെയർ റിപ്പോർട്ട് ചെയ്താൽ that gets classed as an outbreak. അപ്പൊ അങ്ങനെയൊക്കെ ഉള്ള ഒരു പ്രശ്നമൊക്കെ ഒഴിവാക്കാനായിട്ട് varicella vaccine എടുത്തത് കൊണ്ട് there isn't any specific disadvantage that happens. അപ്പൊ I don't understand the rationale behind withholding varicella vaccination from children. It needs to be given, and I think you guess, ഇതിന്റെ കോസ്റ്റ് മാത്രം ഈ പറഞ്ഞ അത് നാഷണൽ ഷെഡ്യൂളിനകത്തൊന്നും മാറ്റിയതാണോ എന്നുള്ളതാണ്. നമ്മൾ ലോജിക്കലി അല്ലെങ്കിൽ പറയുകയാണെങ്കിൽ I believe that varicella vaccination should be offered to children. That is my first.
Thank you, sir. Purushothaman sir was yes, sir.
Two things. We were using VZIG earlier, but almost 10 years back we got it from Bangalore at that time. For recent item, we use it. Ramankutty sir, one question. When we are choosing multicentric studies definitely will add the number when the malignancy and all. We need multiple, just the number. And another thing, the diversity of the population, and maybe a little bit of the treatment methods also. That should be a uniform treatment method, but the diversity. When a problem doesn't add to the diversity, just like this case, the malignancy of this sort, whether it's UK, Scotland, wherever, usually they're all almost the same. Is that needed to be a multi-center unless it is not the number? When the diversity is not being added by the multicentric. So whether that multicentric thing was not there, is it to be mentioned as a limitation here? If there is an adequate number of the sample, should there be a diversity or should there be a multicentric?
That's a very good question. As you say, if you can get enough numbers from the same center, it might be better to get it from the. Usually, why they go for multicentric is because you can't get enough people from the same center. But then adds a kind of what in statistics they call random effects to the, because the center itself becomes a source of variation. So you have to factor that in when you do the analysis, especially when you do regression and all. You have to put in a random effects model and all that. But in a genuine case where you think that the condition is varying between centers, then you probably need that kind of a design. But if you think it's a uniform population, same disease everywhere, then the addition of multiple centers is purely for strength of numbers. And if you can avoid it, it is better. Yeah.
In case they themselves has mentioned that the regime followed for giving acyclovir, the day of starting acyclovir, was all different in different centers. It is not a homogeneous population by any terms. They should have had a uniform management and then analyzed it. I mean, ഓരോ സ്ഥലത്ത് ഓരോ ഇതില് acyclovir dose കൊടുത്തിട്ട് പിന്നെ
എനിക്ക് തോന്നുന്നത് ഒരു ലോജിസ്റ്റിക് പ്രോബ്ലം ആണ്, because they have said it's a service evaluation, because the moment you decide to have a uniform protocol, then it becomes a study and then you have to get informed consent, this that. So I think they have tried to take a shortcut.
Okay.
അവന് സാധ്യത.
Okay.
Sir, it is almost 8:30, so
so wind up.
Yeah, sir. So I was just asking whether, I mean, sir, before stopping, sir, Ramankutty sir, I was reading about this Fisher test and all, and an interesting story was cited there, because this person Fisher was, I mean, the question was whether the in a tea, whether the the tea or the milk was added first. One question was there, and is there a story like that, sir? Do you remember, sir?
I don't remember that. Fisher is a very colorful personality, because if you read his history, it's very interesting. He is one of the founders of what we nowadays use. Most of the tests we use in statistics go back to Fisher, but also he was very controversial. He challenged some of, he didn't really challenge, but he's not accused. He said that, these experiments by Mendel, he said the data of Mendel that he's reported is too good to be true, which is effectively saying Mendel was cooking up his data. But that became a huge controversy. It is still not resolved. There are still books and articles written on who is right, whether Fisher is right or Mendel is right or all those things. It's very interesting, because Mendel's centenary was recent. So I even wrote an article on that in one of the Malayalam Luca portal. So it's a very controversial figure. And what is more interesting, he firmly believed, he was an agricultural statistician. So he went on improving crops. That was his job. So he thought that that should be extended to humans also. So he was a strong eugenicist. He thought that the weaker races should be kind of weeded out, or almost like a Nazi, like
almost like Hitler then.
Yeah, but he didn't, of course, go to that extent, but he was mostly theoretical. But he believed strongly in that. So what has happened now is that in British universities, because of strong political protests and all, many buildings which were in his name, they have removed his name. They have renamed those buildings, because people say that, you know, we can't have this person as because he's a bigot and he is not a fair person. So you should remove his name. So actually in many halls and others which were named after him, they have assumed other names. So he's a very colorful personality, but his intellectual contribution is huge. I mean, it's like there's some, you know, the famous biologist Richard Dawkins has written that after Darwin, the man who changed biology is Fisher because of his contributions. So he's so strong.
Sir. So, I mean, the story went like this actually, the story behind developing the Fisher's equation, like somebody asking whether if anybody can, but just by tasting, can you find out whether the sugar and the milk was added or the tea was added and then added first actually. And that went on to his calculation. Sir, before closing up, there are two clinical questions. I think Dr. Benno is there, sir. Dr. Benno? So the question is that, yeah, sir, sir, one question is in the chat box. How is pregnant at 32 weeks mother with the varicella zoster? I mean, varicella managed, acyclovir or varicella zoster immunoglobulin or termination? Okay, so pregnant 32 weeks mother with the varicella. She's pregnant 32 weeks and she has got this varicella. How is it managed? Management of mother and mother and baby. Options are acyclovir, varicella zoster immunoglobulin, termination actually.
So in the 32 weeks in a termination, it's not told.
Yeah.
But in 32 to 34 weeks, it can manifest with cardiac and GI problems in the baby. So nowhere it's mentioned that you have to terminate.
Yeah, that's true. And usually, we perinatal period, number of days. Number
of days. Immunoglobulin 1 week prior to delivery. Mother varicella zoster infection, then you can plan for giving immunoglobulin.
Okay.
Later on, if the child develops, immunoglobulin later on, if the child develops any lesions, then you can give IV acyclovir. Acyclovir treatment.
Okay, thank you, sir. Thank you. That is
just to make it clear that either termination, it is not an indication for termination. Yep. What they're saying is, in certain studies, they have said that it can cause cardiac as well as GI problems in the baby.
Okay. Congenital varicella syndrome
sir, is the recommendation? What is the mother actually? How is the mother managed? Are we just waiting and watching? Cardiac GI problems all up, sir. Should we wait it out or?
Mothers should be treated with the acyclovir, madam. The chickenpox mother, when the mother is getting chickenpox in the second trimester, especially, varicella affecting the babies is not in the first trimester, mostly in the second trimester. So after that, during the second trimester, if it is getting there's a high chance of malformations, and that time only is the question of this aborting or other things comes. After that, there is no chance of malformation. The problem during that trimester, last trimester part will be both for the mother and baby. The problems or complications of the mother will be just like that any other person, especially a little more chance of complications. So we need to treat with the usual available drugs, valacyclovir, if it is oral, or parenteral, it's a acyclovir, depending upon the clinical scenario. Of course, that will be passing to the baby also. I don't know to what extent the cross transplacental transmission of this thing will be there. So management should be with the available drug. It's not with the zoster immunoglobulin. Zoster immunoglobulin has no role for the treatment.
Okay, sir. Thank you, sir.
Thank you, sir. Ramankutty sir and Padmanabhan sir, Purushottam sir, can we wind up actually?
Yeah,
so coming to a formal thank you note, I would like to thank for IAP Trivandrum all the teachers, Dr. Ramankutty sir, Dr. Purushottam sir, Dr. Padmanabhan sir, Dr. Mary madam, Dr. Benno sir, and the wonderful presentation by 2P postgraduates, Dr. Hiba and Dr. Cilu Mathew, and thank the Dr. Krishnamoorthi sir, Dr. Deepa madam, and I would like to thank all of you for giving us this excellent session and a discussion on the topic as well as the article. And I wish you all a very nice time ahead. Good night, and thank you from here. Take care. Bye. Good night, sir. Thank you so much.
Bye, sir.
Thank you, sir.